this lecture, we're going to talk about the renal system, and particularly, I want to focus on the renin, angiotensin, aldosterone system, or sometimes it's in the book, it's going to be written as renin, angiotensin, aldosterone axis. And why do I want to focus on this? I think it's a very confusing, topic, and it's very important in understanding how medications work, how it regulates blood pressure in the long term, its effects, on congestive heart failure, right? And also a lot of the drug targets that you are either going to encounter in the field or you actually administering from your protocols, they're going to come, working somewhere in the system. So it's important to understand, how the system actually functions and the implications of this, right? What's the normal function? What happens when there's a pathology, and actually the drug targets on the system. So we're going to address all those things, right? And talk about the renal angiotensin aldosterone system, right? BP regulation, how it works in congestive heart failure. Certainly, we're going to talk about ACE inhibitors, right? Medications like captopril, enalapril, right? Anything that, pril ending, right, is a ACE inhibitor. We're going to talk about ARBs, right? These are also medicines. They work on angiotensin 2 receptors, right? And these are called angiotensin receptor blockers. So the ultimate action is to block angiotensin response. We're going to talk about that because it's important. We're also going to talk about the function of furosemide, which is actually in your protocols. And you want to know which protocol you have this drug under in your REMAC protocols?
Stroke protocol.
Stroke protocol. What about your congestive heart failure?
Oh, never mind.
Right. So congestive heart failure, right?
Check congestive heart failure because it helps with pulmonary embolism.
Yeah. So if you look in your acute pulmonary edema or right respiratory distress protocol, it's listed there. It's given for patients who have congestive heart failure. It's a medical control option. But I want to go over how it works, and the function of this, so that when you are calling medical control and you're requesting to give furosemide, how it's going to work on the patient, right? So we're going to talk about all this. So as you guys know, right, we have 2 kidneys in the body, right? And they are in a retroperitoneal area. So you see the kidneys are shown here, 2 kidneys. And then you have the uterus that essentially are leading to your bladder where urine is stored, right? Now, if you also look at the top of the kidneys, right? Let me erase this. At the top of the kidneys, there's this gland here. This gland is also very important, right? It's the adrenal gland. Some of the things, at least one thing, you should know what it secretes, right? And anyone knows what it secretes when in a status of, shock or fight or flight response, I should say.
Epi and Repi.
Epi, right? Very good. So we learn. You guys already know, right? Secretes epinephrine. But today we're also going to learn, right? This gland also is going to secrete aldosterone, right? Aldosterone, and that is particularly important when we're going to address, the renin angiotensin aldosterone system, right? Aldosterone and the function of aldosterone, which is again secreted by the adrenal gland, right? And that's to reabsorb salt and water, right? So we're going to spend some time talking about the adrenal gland, right? Specifically aldosterone secretions. Right, and so this is essentially the major organs of the urinary system that you see here. This is just another diagram to show you the connection. We see that the kidneys have both the arterial supply, right, the arterial supply that comes in and brings all the blood, and then we have the venous, right, outflow that essentially goes to the vena cava, right, inferior vena cava. And we're going to talk about, again, the very important function of your filtration, glomerular filtration rate, right, with the kidneys, how it basically blood circulates, how much it reabsorbs, how much it secretes, and how much is actually coming out of the urine. What's the urine output? So we'll see that. One thing I want to emphasize, and I saw this during skills, right? When you guys are doing your patient assessment and you are using your stethoscope to auscultate lung sounds, right? You guys in the back, especially when you're listening to the posterior lung sounds, you guys are going so low, right, in the back that you're actually putting a stethoscope on the kidneys. So the lungs are higher up, right? than the kidneys. So make sure when you're auscultating your lung sounds, don't go so down on the torso that you're actually putting a stethoscope on the kidney itself, right? You want to be a little proximal to that. This is just something I noticed. Right? So here that gives you a little overview in terms of, the functions. Says regulates blood volume and blood pressure. We're going to spend a good chunk of time, explaining this part of it. We're going to talk certainly about sodium, potassium, chloride. Remember those sodium, potassium pumps, sodium, potassium ATPases, right? Definitely going to play a role here. We're going to talk about blood pH regulation, right? By the way, normal blood pH is 735, 745. We're going to talk about urine formation, right? And then definitely, right, we're going to talk about the drugs, not so much about the toxins, but we're definitely going to talk about the drugs here today, right? So this is what I was saying to you guys, right? We see this stands for thoracic, right? Thoracic vertebra, T12. And this is where your kidneys are located. But you see, right, these are false ribs here. And oftentimes I see you guys auscultating lung sounds on the kidneys, which is a little bit too low, right? You definitely want to be proximal to that. So here we see the posterior portion of the kidneys. Usually, just while we are on this topic, talking about patient assessment, right? If someone you suspect during your assessment has a kidney stone, one test you could do, right, is called, basically what you do is put your arm on the kidney and you tap on it. So you see, put your arm like this on the back of the kidney and you're going to tap on it. This is called costal vertebral angle tenderness, or CVA tenderness. Costal vertebral angle tenderness. And if you do that, you tap on that side and the patient jumps, from the chair, wherever they are at, with a lot of pain, right? That's a positive marker of kidney stones, right? Just something to keep in mind since we're on this topic, right? So if you suspect someone has a kidney stone, right, instead of listening to their kidneys with your stethoscope, right, for your lung sounds, put your palm, right, like this, cover the kidneys and tap with the other hand. If that elicits a significant pain response, probably positive for kidney stones. Okay. So this is just shows you the locations of the bladder, right, the kidneys, and this is just a close-up view. And the ureters, right, lead to the bladder where your urine is stored, and then from the urethra, right, this is where the urine is passed. This is actually a functional, we're going to get to the functional aspect of the kidneys. So they show you the inside of the kidneys. So here we see, right, the renal sinus. We see all these zones, right? The renal cortex. We see the renal medulla, right? The pyramid, the column, lobe. One thing you want to keep in mind as you go from the outside to the inside, the osmolari, amount of solutes, right? The amount of like sodium, potassium that are found there increases. So from here, maybe you'll go from 300 all the way to maybe 1500 milliosmoles. So as deeper you go, there's increased osmolari, right? The other important thing here, right? Your kidneys have functional units called nephrons, right? Nephrons. And just let's see if someone, can tell me, what do you think, right? Every kidney, so we have two kidneys, but every kidney, how many nephrons, which is one functional unit of the kidneys, how many nephrons do you think each kidney has approximately?
Over 5 million?
Over 5 million. So a little too much, but every kidney has, roughly speaking, 1.2 million nephrons, right? So if you combine the two kidneys, you'd probably be sitting, right, 2 million, maybe 2 million plus, right? So if you have good, healthy kidneys, you about have, 2 million of these nephrons, which are actually the functional units, which we're going to talk about. This is basically just from a cadaver, right? To show you the same diagram as this drawing here, right? Show you all these units, right? And this is what we were talking about. So in here, right, if I take a cross section of the kidney, right, we see this nephron, right? This is the functional unit of it. And as I was saying, as you're going from the cortex and you're making your way down deeper, right, through the medulla, your osmolari will increase. So it will go from 300, maybe 500, maybe 700, 800, all the way down. It will become 1500. So your osmolari increases, and this is important when we're going to talk about how the urine gets concentrated and how urine gets diluted. So we'll spend some time, but for now, right, know that as deeper down you go, there's more particles there, and that's why they exert this osmolarity, right? So as we look more in depth into the nephron, right, the blood flow, right, the arterial blood flow, as I said, as it's coming on to your kidney, it's going to first go into the afferent arterial. So this is the blood flow that comes in. Here we have the essentially the Bowman's capsule, and this is where you actually have the glomerular filtration, right? All the blood that's coming into your kidneys. And then as this process is going on, right, through these capillaries, the blood is essentially will leave through the efferent arterial. Then this will all the way, right, go to the renal veins, and then it will essentially go back to your vena cava. So as the blood comes in from the arterial system, it will go through afferent arterial, right, make its way through the capillaries, go through the efferent arterial, and then as it exits, right, it's going to go to renal vein and then back into the circulation. And then we got to basically know, like, what happens here, right, as your blood, or I want to say plasma, right, moves through the nephron, what's the outcomes of that. And then finally, right, through the collecting duct, you actually make your urine, right, that's being secreted. Actually, while we're on this topic, I'm actually going to ask you guys this, right, which is, I think, is important to understand, right? Imagine, let me draw, this is your circulatory system, right? Let's just say this is your circulation. And roughly speaking, right, what is a cardiac output for an adult person?
70.
What is it?
60 to 70%.
In liters, how many liters? Cardiac output, total cardiac output. So let's say I'm sitting right now. What's my cardiac output in liters?
6 liters.
Yeah, 5-6 liters. Very good. So let's just say approximately, right? 5 liters. That's my cardiac output. And you guys remember, right? Your cardiac output is heart rate times stroke volume, right? So far, everybody's with me, right? And we're gonna say, right, from your circulation, from your major circulation, we have, right, the arteries that are bringing blood to your kidneys, right? That comes in through the afferent arterial, then it's going to leave the efferent arterial, and then it's going to become a renal vein, and the renal vein is going to come back to the circulation, right? So so far we have, established cardiac output is about 5 liters. We see the flow to the kidneys and then back to the circulatory system, right? Now, how much percentage out of that 5 liters is going to the kidneys every minute? What's the percentage?
1%.
How much?
1.
1%?
25%?
25%? Who said that?
Brenda?
Brenda, very good. Brenda, so you're very close. Roughly speaking, it's about 20%, right? So you are on point, right? So about 20% of the 5 liters, right, is coming in to the your kidneys, right? So 20% of 5 liters is about 1 liter. So about 1 liter per minute is coming to your kidneys every minute. And now we know, right, if you take, let's say, a blood tube, right, and I put blood there, not all of it is going to be, pure blood. We have cells, right, red blood cells, we have proteins in there, we have plasma in there, right? So if we divide this 1 liter, 40% of it will be cells, right? And then the other 60% is the plasma, right? 60% is plasma, which has, some proteins in it, like big proteins like albumins, right? It has also electrolytes in it. So cells do not go inside your kidneys, right? Inside the nephron. So they bypass the system. But the 60% of the plasma that's coming in here, right, will go to the kidneys, will go inside the kidneys. So if we say 60% on 1 liter, that's roughly, let's say, 600 ml, right? So about 600 ml is going to come here. right? 600 ml is going to come here. But because the flow's so fast, right? 1 liter per minute, 60% of it is plasma. So 600 ml. Truly speaking, again, only 20% ends up going into your glomerulus every minute. So 20% of 600 ml is about 120 ml. So let me actually use a different color so you guys can see. So every minute, about 120 mLs gets filtered through here, right? All the way through this nephron, right? And as it's coming through this, we eventually are going to make urine. And urine is made in this portion here, right? In the collecting duct. And then we're going to pass, some urine. Some urine eventually comes out. So my question now to all of you, right? So we have about 5 liters, right, of cardiac output. 20%, which is 1 liter, is going to come to my kidneys, right? If out of that 1 liter, 60% is plasma, and 60% of 1 liter is 600 ml. If we take 20% of that, that's about 120 ml per minute. That's being now coming into this glomerulus and being, right, going to your nephrons. And then things, there's some ions that are flowing out of it, like sodium. There's some ions that are flowing back to it. There's a little, water that comes out, water comes in. So my question is this: out of this 120 mLs per minute, how much of it comes out from the urine? What do you guys think?
I'm gonna take a rough estimate guess and say about 10 cc's.
So James says 10 ml per minute, right? Because we said 120 came in, and he says 10 ml per minute. Anyone has any other?
I want to say 5.
5.
About
Okay.
5.
5 ml. Anyone else?
I'm gonna agree with James.
James, okay. Anyone here thinks all of this, because some of it is reabsorbed, some of it is secreted. Anyone here thinks all of this 120 ml comes out through here?
No, not all of it.
Not all of it? Anyone here who thinks 120 or close to it, like maybe 100?
Thinking about 80.
80%, 80 ml. Okay. Somebody says 80 ml. All right. So let's see, right? Let's see. So what's the answer? Like, how do we know? So let me from when you guys are giving numbers, let's just put it into perspective, right? Let's say we have 24 hours in one day, right? 24 hours in one day, and then we know 1 hour is 60 minutes. Everybody agree? So then we'll do, right, 60 times 24. So we in one day, right, we have 1440 minutes. Everybody agree? Right? So let's for the sake of the math, let's just say, right, someone said, we said 10 ml, 5 ml, somebody said 120 ml. Let's just say, let's use a whole number. Let's just say 100 ml per minute. So let's do 1440, right, minutes in a day times 100. And this is mLs. So if I convert this into liters, 1, 2, 3, 144 liters. So if you were making 80 mLs of urine, 100 mLs of urine, you would not leave the bathroom because you would have to pass 144 liters of urine per day, right? Anyone seen a liter bottle of water? Right? So now that you're seeing this math, right? So if you're making 80 to maybe 100 mLs of urine, you're basically not leaving the bathroom, right? So what do you guys think? How much urine you make per minute?
Closer to 1 ml.
Yeah, yes. Brenda, I think, was saying that, right? So truly speaking, right, out of this 120 mLs that comes in, only 1 ml per minute is actually coming out as urine. So roughly speaking, looking at these numbers, you're making about 1440 ml of urine. If we say 1 ml per minute, 1440 minutes in a day. You're roughly making, right, 1440 ml. We could make this into a whole number, right, 1500 ml, or about 1.5 liters of urine per day. That's if your physiology is normal, you do not have any problems, right? And that's what usually occurs, right? If you're passing 100 mLs of urine, you would never leave the bathroom. You would have to have a Foley catheter attached to you anywhere you go, right? And emptying out every so often to get rid of this urine. And then we're going to learn about some diuretics, right? Even the most powerful diuretics do not have the capability of increasing urine to this level, right? They may increase your urine, even if they increase your urine like fivefold, right? Maybe instead of having 1 ml per minute, they increase it to 4 ml or 5 ml. That's already super, super powerful diuretic, right? That will have crazy effects in terms of urine output, right? So just a small change, right, in that can have profound effects. So this just gives you a perspective how much urine we make, right? So truly speaking, right, if I were to use percentages, 99% gets reabsorbed. And only 1%, right, is urine. So only 1% of this amount is actually exiting, right, through your collecting duct. All right, any questions here? All right, so as we continue, right, our discussion, right, kidneys also regulating, right, total body water, and we know about 60% for men, about 50% in women is total body water. We have the breakdowns of these compartments. One thing I want to point your attention, right, we hear this term osmolari, right, and it's basically how many these ions, right, these particles, the pressure they exert. So normal osmolari, we say, is about 290 milliosmoles, right, in our body. And we call this an isotonic amount, right? Here we have different compartments, right? We see there is a intracellular fluid. Intracellular means inside the cells, right? Here we see the actual interstitial fluid. This is the fluid found in between the cells, right? And then here we have the plasma, right? This is essentially your blood, and we see, right, the exchange that's occurring here. Now, one thing I remember, I was driving this thing to you guys. I was saying cells are bags of potassium in a sea of sodium, right? You guys remember that? So that's true for all the cells, right? You see how this is intracellular fluid. You see how potassium inside the cells is 120, but if you look at the potassium outside the cells, right, in the interstitial fluid, the potassium here is only 4.5, right, millimolar, right? So the cells have the potassium, and they're in a sea of sodium. So you see, right, inside the cells, the sodium is very low, 15 millimolar, but outside, right, is 145 millimolar. That's why I keep this example to you guys when they call you for abnormal labs in the nursing home. What probably happened is, they shook the tubes that they collected the blood with, right? Those red blood cells, right, they break apart and they release the potassium content. So all of a sudden they look at the blood work and it says potassium level is, I don't know, 40, 50, 60, 100, right? And the problem with that is nobody with that level can sustain life. You will die with potassium, just exceeding that, 10 gradient, right? If your potassium is 10 millimolar, you probably will have, lethal dysrhythmia. So just something to keep in mind. But what I want to focus here, right, is this thing about osmolari, right? So I said about 290 milliosmoles. You guys heard of isotonic fluids?
Yeah.
Yeah.
What is an isotonic fluid?
It has the same sodium content as blood. It's like the normal saline we give is 0.9%.
Okay, so what do you think is the osmolarity of your sodium chloride solution?
1.
1?
0.9.
Ari, is that what you're saying? You said osmolarity of sodium chloride is 1?
Yeah, I'm going with 1.
With 1, right? So if you go with 1, so if your osmolarity of saline is 1, this is how you would essentially send your patient, to a cardiac arrest, right? Because if that was the case, if we were giving them these concentrations of osmolarity of 1, right, it will no longer be isotonic, right? So if you look at your sodium chloride, next time we're in the lab, right? So this is just, I took a picture, right? Look here, right? Sodium chloride, right, 0.9, right? So you notice, right, what's the osmolarity? 310, right? And why is it 310? Because we want to give an isotonic fluid, right, with osmolarity, which is very close to your normal osmolarity that is found in your, interstitial fluid, right, in your blood. How we do this, right? We use, right, sodium chloride, which is sodium and chloride. They're equal amounts, right, to not have net positive or net negative charge. They equalize each other. But one thing you want to note, right, even though it's isotonic, what do you note about the pH of saline? Is it the same as blood, lower or higher?
It's lower.
Lower. So is it acidic or alkaline?
Alkaline.
Alkaline?
So let's. So pH.
Acidotic.
Right?
Acidotic.
Yeah, it's acidotic, right? Because we said normal blood pH is 735, right? 735 to 745. So if you're below 735, you're acidotic. If you're above 745, you're alkalitic, right? So now we see pH 5.6 for saline. So you are definitely acidotic. So here's my question, right? Imagine you have a patient who, you see that they're having trauma, they have a lot of blood losses, and you are giving them IV fluids. You guys love IV fluids, right? Especially in the setting of cardiac arrest. We do these arrests. You're like, all right, we're going to give fluids. I ask how much. Open up 1 liter, 2 liters, right? 3 liters, right? So what do you think infusing this much fluid does to your patient of saline? What do you think is going to cost to their pH?
Go down.
Go down, right?
So,
yeah, very good. So large amounts of normal saline, right? Large amounts, when you go 3 liters, 4 liters, they're going to cause patients to go into hyperchloremic acidosis. So basically, you're going to cause acidosis, right? Secondary to the administration. This is the reason why I bring this up. Next time you're in the lab, right? When you pick up your bags, take a look, pay attention. So even though it's osmotically isotonic, right? They're still causing acidosis to the patient, right? And basically what this is, right? They say, here you see, they adjusted with HCl and F. That's basically hydrochloric acid, right? And this is basically adjusted pH set forth by this national formulary NF. So they make it, they adjust the pH, but still it's not in the pH range of, same pH as your blood. So be cognizant of that, right? So this is the compartments. Now, I'm just going to briefly talk about the receptors. So this diagram here shows you different channels. I spent some time talking about some of these channels, but the ones that are particularly important for kidneys are going to be the sodium-potassium pump. And I think you guys recall this, right? We had the same pump in your cardiac cells. We had the same pump in your neuronal cells. All right, it's driven by ATP, right? So you see how you have ATP, you need energy. You need energy because it's working against the concentration gradient. What does it do, right? It pumps, right, 3 sodium out for every 2 potassium in, right? The way I want to remember is, right, Na plus, so 1, 2, 3, so there's 3 of them. K plus is 1, 2, so there's 2, right? You're using energy, right? So we're going to talk about these. There's also the channels that are important, right? We're going to talk about potassium and sodium channels, right? For our purposes for the kidneys. And then the other channel that I think is important for you guys to know, right? So this just shows you a little close-up view in terms of the sodium-potassium ATPase, right? They're utilizing the ATP to, remove sodium, right? And then bring in potassium. So this we'll talk about extensively. The other channel that's important is this channel here. This channel is called sodium-potassium 2-chloride transporter, right? It's found in your kidneys, especially in the distal convoluted tubule, right? Distal convoluted tubule, if I go to this diagram back here, right? Right, you see this number 4, right? Distal convoluted tubule that I'm circling. So distal convoluted tubule is where you see this channel, sodium potassium 2 chloride transporter, right? Does anyone know what drug affects this transporter? This drug will come here. Actually, let me do it like this. This drug will come here. And this drug will block this transporter. Anyone know of the drug that blocks this sodium potassium 2 chloride transporter?
Is it a loop
What is it, Ian?
a loop diuretic like
Like what?
Lasix, furosemide.
like LASIK?
Yeah, very good, right? F for furosemide. Right? I even drew this for you guys, right? So F for furosemide. So what it does, right? You see it blocks sodium potassium 2 chloride. We're going to talk about specifically, right, the effects of this. But in your mind, what you want to remember, right? Furosemide they call them loop diuretics, right? And the way they work is they block the sodium potassium 2 chloride co-transporter, which is found, right, in distal convoluted tubule, which I circled here, right?